all of the listeners. I am Dr. Dibyendu Roy. I am a consultant gynecologist from Kolkata, India. I am going to present a case report titled as a cheaper alternative to conventional mid-urethral sling surgery for stress urinary incontinence can also have a comparable obstetric outcome in long term. Sorry. As per International Continence Society, stress urinary incontinence is defined as the involuntary leakage of urine per urethra during increased intra-abdominal pressure like coughing, sneezing, or exercise, when intravesical pressure exceeds maximal urethral closure pressure in absence of detrusor contraction or urinary tract infection. Stress urinary incontinence is one of the commonest form of urinary continence in women. The other type of incontinence are urge incontinence, overflow incontinence, and mixed type of incontinence where there is both urge variety and stress variety. The reported prevalence rate of stress urinary incontinence is in between 20 to 40% in the middle-aged and the older women. Age is an independent risk factor for the development of stress urinary incontinence. As older age is associated with decrease in the pelvic floor muscle tone, decrease in the bladder muscle tone, and increased incidence of urinary tract infection in the postmenopausal woman, these all factors together can lead to the increased incidence of stress urinary incontinence in the older women. The peak incidence of stress urinary incontinence can be seen in the 5th decade of woman life. While considering the treatment option for stress urinary incontinence, mid-urethral sling operation is the surgery of choice by means of transobturator tape or transvaginal tape. This type of sling surgery are somehow costly, and the cost is variable depending on the manufacturer of the tape. And as these items are not readily available in many centers of the country, the in-house or indigenous method are being increasingly in use in many places of India. So in normal women, when there is rise in the intra-abdominal pressure, the intravesical pressure also rises. But at the same time, in normal women, the urethral closure pressure always remain at the higher level than that of the intravesical pressure. That's why the woman can remain continent even in the time of increase in the intra-abdominal pressure. But in case of stress urinary incontinence, there is increase in the intravesical pressure, and that will remain above the urethral closure pressure. So the woman will experience leakage of urine during the time of stress. So how can mid-urethral sling surgery can be helpful in the woman with stress urinary incontinence? Mid-urethral sling surgery consists of placement of a mesh or tape in the mid-urethral region, which will act as a hammock. So when there is increase in the intra-abdominal pressure, that pressure also transmitted to urethra, and the urethra get compressed on the sling and it get closed. So the leaking of the urine is controlled. By this way, mid-urethral sling surgery can be helpful in the treatment of stress urinary incontinence. Transobturator tape is the most commonly performed mid-urethral sling surgery because of its simplicity. This operation required a transobturator tape kit, which will consist of 2 transobturator tape needle, TOT needle, and as you can see, this is the sling. This is the needle and this is the sling. and it will cost around 25,000 to 32,000 in Indian rupees. If we come to the procedure proper, the transobturator tape procedure will begin with the positioning of the patient in the lithotomy position, and after that, a incision is made on the anterior vaginal wall 1.5 centimeter below the external urethral meatus, and two other separate incisions are driven over the groin just at the junction of the labiocaudal fold 1.5 centimeter below the insertion of the adductor longus muscle. After that, the dissection of the bladder is done from the anterior vaginal wall to facilitate the placing of the mesh. After the dissection of the bladder is fully completed, the needle that has been shown in the picture is introduced to the groin incision and it is taken out through the vaginal incision. Once the needle is fully out through the vaginal incision, the tape that is need to be placed in the mid-urethral region is attached with the tip of the needle, and again the needle is taken out from the same groin incision, and the same procedure is repeated on the other side also, and that will make the mesh in place. And after the mesh is in place, the vaginal incision and the groin incision are closed with appropriate suture. And in our case, a 30 years old lady, para 2+0 with previous to vaginal delivery, with a BMI of 31 and from a low socioeconomic status, presented to us with stress urinary incontinence with significant quality of life impairment. After detailed history taking and physical examination, the diagnosis of stress urinary incontinence is confirmed, and according to the guideline, the woman was advised to continue the conservative management by means of weight reduction, local estrogen cream application, and Kegels exercise for 3 months. But after 3 months, there was no improvement in the symptoms of the woman. Rather, the woman developed some depressive disorder. And for this, the decision for transobturator tape surgery was taken. The woman underwent all the pre-operative preparation and every investigations were within normal limit, and after proper counseling regarding the type of surgery, the complications and the recurrence of stress urinary incontinence after mid-urethral sling surgery was explained to the patient in details. As the patient was from a low socioeconomic background, she was not being able to afford the conventional kit that I have already shown in previous slide. She was unable to bear the cost. So we need to improvise or to customize the TOT kit. We have used the Prolene mesh that is being regularly used in our OT for hernia repair, a Prolene suture, and an indigenous TOT needle, and that reduces the cost of the operation to about 10 times, and that found to be greatly beneficial for the woman. This is how we have transferred the simple Prolene mesh into TOT kit. You can see we have taken a 11 centimeter strip of the Prolene mesh, and we have attached the Prolene suture on both ends of the mesh. This is how it has been converted to the TOT tape. The operation went uneventful and the post-operative period was also uneventful, and the patient was discharged on post-operative day 3 without any complications. Then after, 1 month and 3 months and 6 months follow-up, the woman was found to be continent and she is having a greater quality of life after the operation. But after 1 year, the patient got pregnant and she was presented to our antenatal OPD regularly, and as she has no medical disorder and she has previously been delivered vaginally twice, the decision of trial flavor for vaginal delivery was taken in spite of previous mid-urethral sling surgery. And the patient admitted with true labor pain in our labor room, and she delivered spontaneously vaginally a 3 kg weight baby without any complications. Previously, caesarean section was the preferred route of delivery for the woman who underwent sling surgery due to the fear of stress urinary incontinence recurrence. But according to Hussar et al., the risk of SUI recurrence is not significantly increased even after vaginal or caesarean section delivery. Like in our patient, the patient was followed up after 6 months of delivery and after 2 years of delivery when she is very much continent and having a great quality of life. So to conclude, I want to emphasize 2 points: that the hernia mesh and the indigenous needle can reduce the cost of the surgery significantly, and that can be very much helpful for the patients who are belonging to the lower socioeconomic status. And other point is, even after mid-urethral sling surgery, vaginal delivery can be done without significant increase in the risk of recurrence of stress urinary incontinence if the primary incontinence surgery and the delivery are done in proper way. This is all. I would like to thank all of you for your patience learning, patience listening. Thank you all.
Quality standards of the NABH and NABL. Coming to introduction, accreditation is a procedure by which an authorization body gives a recognition that an organization is competent to carry out the special quality works. NABH is a constituent board of Quality Council of India set to establish with the objectives of enhancing health system, promoting continuous improvement and the patient safety. Just within a few years of its launch, the Indian accreditation standards NABH was accepted by the International Society for the Quality Assurance, that is ISQA, as an international accreditation on par with the world's best. Though developed by the Quality Council of India on the lines of international accreditation standards, the NABH is, however, seen as a more practical set of standards and very relevant to the India's unique healthcare system requirements. The NABH standards is today the highest benchmark standards for the hospital quality in India. NABH standards are equally applicable to government as well as the private hospitals. The government and private corporate hospitals, by the virtue of their objectives, undergoing certification for various accreditation standards. But NABH standards are dynamic and would be under constant review process, shall facilitate to deliver safe, high quality care for the hospitals. What are the benefits of accreditation? Accreditation benefits will be divided into benefits to the patients and the hospital as well as the staffs. So patients are biggest beneficiary among the all stakeholders, results in quality of the care, patient safety, and patients are serviced by the credentialed medical staff. Rights of the patients are respected and protected, and patient satisfaction is regularly evaluated. Benefits to the staff. It provides continuous learning, good working environment, leadership, and above all, ownership of the clinical processes. It improves the overall professional and skill development of the staff. Benefits of the hospital. This provides empanelment by insurance and other third parties. It provides access to reliable and certified information on facilities, infrastructure, and level of care to the laboratories, that is NABL. The aim of the study was to study the requirements of quality standards of NABH, try to implement those quality standards, and to evaluate compliance of the implemented standards in terms of quality of the health services. Objectives of this study were divided into general and specific objectives. General objectives to study the requirement of the quality standards of NABH in District Hospital Vijaypur. Specific objectives to study the present quality assurance system with the requirement of quality standards as per NABH and enable for good patient care. To study the change in the quality practices for improvement of the patient care also. Coming to materials and methods, study design. This project study is a descriptive analytical study. Before proceeding to the project study, we should know about NA-based cell organization structure as shown in the figure 1, and we should also know about the NA-based accreditation procedure as in the figure 2. This is the figure 1 showing the organization structure of NABH, and NABH there will be appeals committee and different committee like accreditation committee, technical committee, and secretariat, and panel of assessors, experts also. This is the figure 2 showing the NABH accreditation process. First, we should apply for the accreditation process and self-assessment by HCO, that is healthcare organization, and acknowledgement and the scrutiny of the application will be done by secretariat, and pre-assessment visit will be carried out by assessment team, and final assessment of the hospital by assessment of the team, and review of the assessment report will be done by NABH secretariat, and then recommendation for the accreditation by accreditation committee, and approval for the accreditation by NABH chairman, then issue of the accreditation certificate by NABH secretariat. We should follow the steps for preparing for NABH accreditation as in the figure 3, and also we should know all NABH quality standards as per the each chapter as in the figure 4, and then we should prepare the schematic representation of project design as in the figure 5. This is the figure 3 showing steps for the preparing for NABH accreditation. Obtain a copy of the NABH standards from NABH office, then get accustomed to the standard and implement by healthcare organization. Then obtain a copy of the application form from NABH website, and then fill it and submit the application form to NABH secretariat office. Pay the accreditation fees. Then this is a figure 4 showing the NABH quality standards, and there are NABH quality standards chapters are divided into patient standards and the organization center standards chapters. This is the figure showing the schematic representation of project design. Here groups of staff were taken and pre-test to study the requirements of standards and the evaluation of the quality standards in the hospital, and intervention by implementation of the quality standards of the NABH and enable in the hospital. Post-test was should be conducted to evaluation of the implementation of the gaps at the end of the study. Recommendation, action plan to improve the gaps found after the study. We should do the pre-project situational survey analysis and analyze the quality standard situation in the facility. So pre-project situational survey analysis carried out by internal assessment committee, and gap analysis done among 1 or 2 standards. Few were implemented and others to be required implementation during the project period. For the implementation of non-compliance quality standards, action plan is required. According to the implementation, requirement action plan is prepared. In the action plan, sensitization about all NA-based quality standards to the staff is planned and trainings are conducted. Many committees are formed which supervise the implementation of the quality standards across the different functional areas of the hospital. We should do the pre-project study design, and this project also consists of pilot questionnaires. These pilot questionnaires prepared. These questionnaires were arranged for 20 to 40 IPD patient and 10 to 20 OPD patient interviews were taken. Questions were typed in the prescribed format about the patient services where they met about billing, receipt, departmental services and water facility services, etc. And if patient is educated, he should attempt the patient satisfaction report and tick the answer. If he is uneducated, he can give his opinion with the help of staff nurse or the attenders. Patients will write their experience about the services and give their valuable suggestion regarding the improvement of the quality services of the hospital. At the end of the project study, the internal assessment committee do the internal assessment of successful implementation. Successful closing gaps are assessed and remaining gaps are identified and action plans are prepared to fill those gaps. Patient satisfaction report format also collected, analyzed, suggestions are discussed. For implementation of the patient suggestions, action plan is prepared. From the whole analysis, conclusion is made and necessary recommendation and suggestions were prepared. NA-based quality standards. It provides framework for the quality of the patient care and the quality improvement for all levels of health organization and help to build a quality culture at the hospitals. These standards for hospitals prepared by technical committee which have plans to evaluation of complete set of standards for grant of the accreditation at the hospitals. Standards have 10 chapters as in the figure 4, incorporating 102 standards and 636 objective elements. So chapters were divided into patient-centered standards and the hospital-centered standards. And under a patient-centered standards, chapters are: one is access assessment and the continuity of the care. Second one is the care of the patients. Third one is the management of the medication. Fourth one is the patient rights and education. And fifth one is a hospital infection control. Organization-centered standards are continuous quality improvement, responsibility of the management, facility management and safety, human resource management, and information management system chapters. Study area, District Hospital Vijaypur, Karnataka State, situated in 115 acres. Building area is about 60 acres and having 426 beds. Hospitals covers 5 talukas and more than 100 villages and 14 lakhs of population. All community people will visit to our hospital because as this hospital has highly skilled staff and multi-specialty doctors and around the clock they will give the services. This hospital has good team of 31 doctors, including the different varieties of the specialization. And Group B were 18, and Group C were 73, and Group D were 64. Totally 186 staff are working in District Hospital Vijaypur. And hospital has a department of like medicine, surgery, gynecology, pediatrics, psychiatry, dermatology, radiology, dialysis, pathology, biochemistry, microbiology, and department with the high technical laboratories and physiotherapy unit. And visiting departments are cardiac, oncology, and WHO health consultant to SNCO also. Study population, where we covered 5 talukas and more than 100 villages encompassing of 14 lakhs of population. Population profile, population is belongs to below poverty line, older 60 to 80%. Majority are literate people. Malnutrition on children are highly among 60% of the pediatric age. Only 1/3 of the children are with normal growth. Severe anemia in ANC more than 2/3 of the total maternity case. Average HB is about 8 to 10 grams. Majority patients are maternity, ART patients, pediatric chronic anemia, and thalassemia patients who need blood transfusion on and off. Around 40% of the hospital patients are coming from the backward remote villages. Sample size for the implementation of NA-based quality standards across the facility. All hospital staff were selected, and for patient satisfaction report form, questionnaires interviews arranged for 20 to 40 IPD randomly for different wards and 10 to 20 outdoor patients randomly from drug counter, reception area, cash counters, OPDs, lab and X-rays and USG physiotherapy units. Criteria for sample study, inclusion criteria, we had patients selected from District Hospital Vijaypur and patients who are cooperative and willing to participate in the study. Exclusion criteria had patients who are not available during the data collection and patients who are not willing to participate. Study period, this project is studied for 45 days, started from 15 to 2016 to 31 to 2016. Research tools, proceedings with the study, prepare requirements of the hospital for accreditation procedure, situational survey by internal assessment committee carried out to create a baseline documents as a situational survey report. This survey does the analysis and evaluation of the quality standards and identify the gaps. Results of the situational survey report, development of the action plan to bridge gaps of the quality standards and implementation process and monitoring. Assessment criteria, a hospital willing to be accredited by NABH must ensure the implementation of the NABH or NABL standards. The internal assessment committee will do the assessment of the implementation of NABH standards in the organization, intra-department, inter-department wise, and submit its assessment report as internal assessment report to core assessment committee. Core assessment committee will review this internal assessment report, assess, and plans accordingly as in the figure 6. The hospital shall be able to demonstrate to NA-based assessment team that all NA-based standards as applicable and are followed strictly. So this is a figure showing the assessment. The intra-department and interdepartmental and core committee assessment is necessary. Coming to process, prepare the requirements of the hospital accreditation procedure. The requirements of the NABS standards shall have to be identified, evidenced by data gathered, analyzed, and interpreted with the aim of the improving the quality system of a hospital. Apply for the accreditation by filling the application form to take participation in NABS accreditation. Organization can obtain the application form from NABS accredited office or download from the website as shown in the figure 2 and proceeded as figure 3. Our hospital downloaded the form website, filled and signed by the district surgeon and submitted to the same office with the help of KHS DRP and Estron Consultant 9 Private in December 2014. Then activity started slowly. Staffs are trained at Bangalore, gained movement after few visits of an NABH consultant, slowly progressed to the situational state. Obtain copy of the NABH Enable quality standards from NABH Enable office as shown in the figure 3. So obtained a copy of the same and consists of 10 chapters as figure 4, 102 quality standards and 636 objective elements. Situational survey to carried out to create a baseline document. Situational survey to carried out to study the baseline situation of the facility with available documents. Survey to carried out from 16 to 20 to 2016. To carry out survey, internal assessment committee formed. This committee consists of all various committees head. According to the quality standards guidelines, NA-based this committee conducted the situational survey. This team studied and evaluated each quality standards according to the chapter-wise serially and following situational survey report submitted to the core assessment committee. Results of the situational survey report, all 102 quality standards are studied thoroughly. Following results are obtained as figure 7. Total quality standards are 102, total compliance quality standards are 52, and total non-compliance quality standards are 50. Gap areas are identified in various departments like reception, counter, OPDs, wards, and lab and OT. So this is the figure showing among 102 quality standards, 52 are implemented and 50 are to be implemented during the project period as per the situational survey. Action plan needs to bridge the gaps. The action plan to implement the quality standards in our hospital prepared as a systemic approach. This systemic approach consists of the following 4 steps. First one is the initiation, then documentation and structural requirements and the statutory requirements. Initiation involves following steps. First one is a constitutional of teams, second is the sensitization, and third one is the understanding standards. Constitution of teams. Chapter champions we made for constitution of the team meeting conducted by district surgeon and NABH coordinator on 15/2/2016 at the district surgeon chamber. Under their guidance, HODs are made as a star champions, allotted each chapter and assigned their responsibility to implement their chapter quality standards across the facility. Total, according to the situation survey report, 50 non-compliance standards were identified and star champions are assigned work to make these non-compliance standards into compliance. Star champions, all head of the departments made as a star compliance of their department, they assigned to the implement the respective standards in their department. Co-champions, all senior staff made co-champions, assigned the work to help the chapter champions and the co-champions implementing the quality standards also. Committees, we formed various committees like core assessment committees, internal assessment committees, safety quality, hospital infection committee, quality improvement committee, and pharmacotherapeutic committee and audit committee. Sensitization to all staff of the hospital. Sensitization about the quality standards is necessary. Sensitization of the staff can be done by conducting the various trainings as according to the training plans as shown in the figure 8. The chapter champion should made to the sensitize all staff regarding their allotted chapter standards. Training schedule should be planned. According the schedule, training should be conducted. All training activities should be documented properly. Trainings of staff, so central versus departmental, internal versus external, theoretical versus practices, mock drill versus practices, and training of the evaluation conducted. Understand the quality standards. All star champions, co-champions should help and guide the staff in understanding the each quality standards of NABH. Documentation. Policies. Each standard has to develop policies which should describe the type of the services going to cater the with the available resources. Example, admission discharge policies. All HODs prepares respective departmental policies as per the NABH guidelines in our hospital. Procedures. All departments should have standard operating procedure. All departmental HODs prepared respective departmental SOPs as per the NABH guidelines. Manuals. All departments should have manuals. Department head should prepare their respective department manual. QIC should prepare hospital quality manual. So all manuals are prepared as per the NABH guidelines. Each department have criteria and protocols for each procedure in their department as NABH guidelines. So all department HOD should stick to respective criteria and protocols as per the NABH guidelines. Each department should prepare forms, format, checklist, and SOPs as per the guidelines. All department HODs prepare them. Structural standard implementation plans. Each department heads prepare necessary infrastructure plans, which includes required human resources, equipments, and materials, and submit that list to authority. So all department HODs prepare this and submitted accordingly. Authority should take the action. So statutory mandatories, licenses and certificate, general wear, biomedical waste management and handling authorization, registration with the Establishment Act, registration with the local authorities, facility management, and fire NOCs, licenses for the diesel storage, license to store compressed gas, registration for the boiler, sanction and license for the lifts, radiology, registration for modalities. And radiology also registration for modality. Process of implementation of the quality standards. Aim of this process to ensure that NABH quality standards are implemented and integrated with the hospital functions. All chapter champions should study the non-compliance quality standards as observed in the situation survey report took necessary actions, formation of the committees, training to the staff, prepared necessary documents, re-sensitized the staff about the plan to bridge the gaps. Authority provided the structural equipment and the statutory requirements also. In implementation of the quality standards, it also involves the important program is implementation of the quality indicators. These quality indicators are documented statistical measures of the quality of the services. QIC committee conducted the training to the staff properly about all NA-based quality indicators, how to fill the quality indicators forms and calculation, submission and periodic distribution and collection back process. And this all process should be supervised by QIC. The most important quality indicators is the patient satisfaction feedback form, which highlights the quality of the hospital services, helps in improvement. So QIC conducted the trainings to the staff from 2016 to 24 to 2016, and from 25 to 2016 distributed the quality indicators forms to all functional areas of the hospital. Implementation of the non-compliance quality standards and the quality indicators program started from 25 February 2016 to 25 March 2016 under the guidance of Internal Assessment Committee. Process of the implementation of the quality standards. Similarly, hospital HIC should conduct training about the HIC practices like biomedical waste techniques and hand washing techniques implementation, and about the BMW checklist and hand washing checklist. HIC should conduct demonstration of the BMW program hand washing techniques. Then HIC people should ask staff to demonstrate. HIC will supervise the staff demonstration and write the checklist. Periodically, this program should be conducted by Hospital Infection Control Committee. Monitoring. Implementation process strictly monitored by the Internal Assessment Committee from 25 February 2016 to 25 March 2016, and they guide the staff properly during this period for correct and successful implementation of the non-compliance quality standards. Quality indicators program monitored by the QIC, HIC practices are monitored by the HIC. Data analysis and observation. All implemented quality indicators, forms, formats, and data are collected from 26 March 2016 to 27 March 2016 by QIC and the HIC committees and compiled and analyzed the data. Then 28 March 2016 submitted their supervised report as quality indicators data analysis report to core assessment committee. At the same time, from 26 March 2016 to 28 March 2016, internal assessment committee did the intra-departmental and inter-departmental wise assessment as shown in the figure 6, and submitted its internal assessment report to the core assessment committee on 29 March 2016. Finally, core assessment committee analyzed the quality indicators data analysis report and internal assessment report on 30th March 2016, observed for the implemented standards and their compliancy and non-compliance, and prepared the final report on 31 March 2016. So core assessment committee continuously, it will do its work and putting continuous efforts as shown in the figure 9. This is the figure 9 showing the continuous efforts by the core assessment team. It will analyzing the assessment results and it will identify the weak areas and it improve the weak areas, and it will retraining and reformation of the documentation, and it will do the reassessment also. And this continuous process will be going on. Final report of the quality standards by the core committee, core assessment committee as follows. Core assessment committee reviewed, analyzed quality indicators data analysis report and internal assessment report on 30th March 2016 and observed the successful implemented quality indicators and formed final report on 31 March 2016. Among aim of the implementation of the total 50 non-compliance quality standards in the facility during the project period, it has observed at the end of the project, there are totally 37 quality standards are successfully implemented under the guidance of NA-based coordinator and with the help of all committees' efforts and staff orientation and dedication, and with the support of organization authority. Core assessment committee confirmed that implemented 37 quality indicators are implemented and are successfully adopted by the staff across the facility, and also they are actively performing this program. Final report of the quality standards by core. Randomly in wards, OPDs, patients and their attenders submitted their patient satisfaction feedback reports to QIC committee. This QIC submitted these patient satisfaction feedback reports along with the quality indicators data analysis report to core assessment committee. All these patient satisfaction feedback reports also studied and analyzed by the core assessment committee and noted that patients and attenders are given valuable suggestions regarding the improvement of quality of the services across the facility. Core Assessment Committee also noted hospital infection control practices checklist, that is a BMW checklist and hand washing checklist. Within a project period, most of the checklist reports shown staffs are made competitive in the hospital infection control practices. Coming to discussion, hospital is an integral part of the healthcare system. Accreditation would be the single most important approach for improving the quality of the hospital. So our hospital also decided for the accreditation to improve the quality services. Often measuring the quality in the facility has never been easy, more so in the public health facilities. So there must be quality linked measurement system, which primarily role is to provide effective means to assuring the patient's requirement are met fully. NABH is a member of ISCO Accreditation Council. NABH is a founder member of the proposed Asian Society for the Quality in Healthcare being registered in Malaysia. The establishment of the quality system in healthcare organization facilities the standardization of the system and processes in both clinically and at administrative levels. The main pillars of the quality measurement system are quality standards. The quality system thus acts as a vehicle for the quality care at a hospital. The NABH quality standards are totally 102 and 636 objective elements. The objective elements are measurable components and these are required to be met in the order to meet the requirements of the particular standard. In our hospital during project period, taken lot of care to meet the requirements of each single standards also. All NABH 10 chapters are deciding factors to say whether hospital is meeting the requirements of the accreditation standards. These standards are dynamic process and would be under constant review process, which was done carefully during our project study period. NABH pre-accreditation entry-level standards will soon be followed by pre-accreditation progressive level standards as an intermediate stage to full the accreditation. Similarly, in our project study, among out of 50 non-compliance standards, 37 standards successfully made compliance and entered from pre-accreditation entry level to full accreditation level, and remaining 13 non-compliance standards entered from pre-accreditation entry level to progressive level, for which plan of action to be taken further to make them fully compliant. So, our hospital successfully implemented and adopted a majority NABH quality standards, hence itself prepared for the accreditation process. Recommendation plans can be done for those non-compliance quality standards to convert them to compliance quality standards. Hence, we can go for the accreditation easily in future. Coming to conclusion, this study concluded that by studying the requirements of the quality standards of NABH bar NABL, we can easily implement the quality standards of NABH bar NABL, by which there is a scope for improvement in quality of the health services, improve in skills and responsibility of the staff, and can meet the patient's expectation also. These are my references. And this is my citation of this article. Thank you, everyone.
Rather good afternoon. Bismillahirrahmanirrahim. I am Dr. Amara Rooj, working as Assistant Professor OBGYN and a Clinical Coordinator of Undergraduate Teaching in Rawalpindi Medical University, Rawalpindi. Today, I will present my research on factors affecting early initiation of breastfeeding among the women delivered in a tertiary care hospital. As I am affiliated with the Rawalpindi Medical University, it is one of the leading universities located in Rawalpindi, Pakistan, and it has 3 affiliated hospitals, public sector hospitals, Holy Family Hospital, Rawalpindi Teaching Hospital, and Benazir Bhutto Hospital. Currently, I am working in Holy Family Hospital, which is one of the largest public sector hospital in the area, serving the diverse population of the patient from the vast catchment area. Now coming to the background, the early initiation of the breastfeeding is defined as the initiation of the breastfeeding within 1 hour after the birth, and it is recommended by WHO and UNICEF to start the breastfeed within the first hour of life, followed by the exclusive breastfeeding for the first 6 months and continued breastfeeding up till 2 years of life. It has many advantages, maternal and as well as fetal, as it increases the chances of immediate skin-to-skin contact and the increased chance of intake of colostrum, which is rich in antibodies. It reduces the risk of the postpartum hemorrhages due to increased release of oxytocin. There is increased chance of early bonding between the mother and the newborn, and it also reduces the neonatal morbidity and mortality. Worldwide, approximately 3 million neonatal deaths occur every year. 22.3% of the neonatal deaths could be prevented by early initiation of breastfeeding. And it can also reduce the infant mortality rate by 11.6%. Despite its advantages, globally the intake of the early initiation of breastfeeding is low. It is about 42% in 2017. In Asia, it is still low, around 38%, and in Pakistan, it's only 18%, with 37.7% rate of exclusive breastfeeding. So there are many factors affecting the feeding practices, including the demographic, socio-economic, and cultural practices. And it also includes the postoperative pain, mode of delivery, parity, perceived inadequate milk production, poor knowledge about the feeding practices and early initiation of breastfeeding, baby reluctant to feed, neonatal admissions in nursery, prematurity, and lack of training of the healthcare workers. So a study done in South Asia found the wider variations in rate of the early initiation of breastfeeding among different countries depending on the differences in socioeconomic and geographic location and cultural variations. Various countries are trying hard to implement the WHO policies and evaluate the local situations of early initiation of breastfeeding practices to find the ways and means to improve it. So this study was done to determine the proportion of early initiation of breastfeeding among the women delivered in a tertiary care hospital before discharge and to identify the factors affecting it. It was a cross-sectional analytical study done in the Obs and Gynae department of Holy Family Hospital for the duration of 6 months from September 2022 to February 2023. We included 380 postnatal patients. The sample size was calculated by WHO calculator using 95% confidence interval and 5% margin of error. Sampling technique was convenient non-probability sampling. We included the women who delivered live babies through vaginal or cesarean section and were willing to participate. And we excluded the seriously sick and unable to participate patients and the neonates with cleft lip and palate. Permission from the University Ethical Review Board was taken. Informed consent was taken from the enrolled patient. Data from the delivered patient before discharge were collected through a structured questionnaire. Then the data were analyzed using the SPSS version 26. Descriptive statistics were used to calculate the percentages and means. Chi-square test was used to evaluate the association of the independent variables with early initiation of breastfeeding. followed by the binary logistic regression analysis to diagnose the factors independently associated with early initiation of breastfeeding. P-value of less than 0.05 was considered significant. This was our performer having the 5 component, and this was designed by extensive literature search and expert opinion. The 5 components were the demographic component, reproductive characteristics, socioeconomic characteristics, feeding practices, and the guidance and the help provided by the family members or the healthcare workers. This was in Urdu language. Now coming to the results of our study. Total participants were 380. The mean age of the participants was 27 years. The mean gestational age was 37 weeks. Regarding the socioeconomic status, mostly belong to the lower socioeconomic status, about 70%, followed by the middle socioeconomic status, about 29%. Mostly about half of the participants, 53%, had no formal education, followed by the education up to the middle grade, that is the grade 8, about 40%. Most of the women, 61%, were multifarious, having 2 to 4 children, and about half are delivered by the vaginal route and cesarean section. 54% neonates were male, 46% were female, and most babies, 81%, have the weight between 2.5 to 3.5 kg. Now coming to the feeding practices, out of the total 380 participants, 256 participants or 67% had breastfeeding, while 124 participants, that is around 33%, had never breastfed the babies. Out of the 67%, only 12.6% females or the new mothers initiated the breastfeeding within the 1 hour of the feeding. That is the rate of the early initiation of breastfeeding from our study was only 12.6%. While the others, 54%, that is 208 out of the 380, they had the delayed breastfeeding, most commonly between 2 to 12 hours. 41% had the started the breastfeeding from 2 to 12 hours of the delivery. And the most common first feed which was given was the formula milk in 34% of the patients or the participants, most commonly prescribed by the healthcare workers, about 56% on demand of family or patients. Guidance for the early initiation of breastfeeding was provided by the family members in 27% of the women. Next were the healthcare workers, 12%, who provided this guidance to the women. Regarding the previous feeding practices, 62% had the breastfeeding in the previous child, while 6% had not this experience. Now coming to the reasons for the delayed initiation of the breastfeeding, from our study we found that the most common reason for the delayed initiation of the breastfeeding were the neonatal admissions in the nursery. It was found in about 29%, followed by the post-operative pain in about 25%, 51 participants. Then the third important reason was the perceived inadequate quality or perceived inadequate quantity of the milk. So the most common reason for the delayed breastfeeding was neonatal admission in 29%, followed by the post-operative pain, 28.6%, and perceived inadequate milk quality in 24.2% participants. On the initial model, on the chi-square test, factors having the significant association with early initiation of breastfeeding were the mode of delivery, p-value 0.00, availability of guidance or help by the family members or healthcare representatives, p-value 0.001, and sex of the baby, p-value 0.044. There was no significant association between the early initiation of breastfeeding and the age of mother, socioeconomic status, education level, and weight of the baby. Then on our final model, on binary logistic regression analysis, factors significantly associated with early initiation of breastfeeding were the mode of delivery, vaginal, is more associated with the early initiation of the breastfeeding, with p-value of 0.000 and adjusted or odds ratio of 24.175, followed by the parity, with multiparity having the more chances of early initiation of breastfeeding with p-value of 0.026, with odds ratio of 2.518, followed by the guidance or help provided by the family members or the healthcare workers with p-value of 0.001 and odds ratio of 3.05. So these three factors are independently associated with the early initiation of breastfeeding, mode of delivery, parity, and guidance and help provided by the healthcare workers or the family members. Additionally, we collected the data from 30 healthcare workers, including the 18 postgraduate trainees and 12 nurses. Majority of the healthcare workers, 93%, advised the early initiation of breastfeeding in the postnatal period. Only 7% advised in the antenatal period. According to the healthcare worker, poor knowledge about the importance of early initiation of breastfeeding, postoperative pain, and baby in nursery were common causes for the delayed initiation of breastfeeding. Most common suggestion to increase the early initiation of breastfeeding was counseling in the antenatal clinic. Now coming to the discussion, the overall parameters of the breastfeeding were low in our study. The rate of the early initiation of breastfeeding was only 12.6% as opposed to the recommendation by WHO and UNICEF, who recommends that every newborn should be put on breast within first hour after the birth as it gives them the best chance to survive. This difference might be due to the disparity in the study setting, as most of the other studies were community-based. We found cesarean section is more associated with delayed breastfeeding due to the post-operative pain, delayed transfer from the recovery room, transfer of the neonates to the neonatal ICU care. This can be overcome by providing the physical and psychological support to these mothers by their family members and healthcare workers. There should be adequate pain relief and there should be agreed criteria for transfer of neonates to the NICU to increase the possibility of early initiation of breastfeeding. Multiparity was another significant factor associated with early initiation of breastfeeding. This means that primiparous mothers need more counseling in the antenatal period and help from the healthcare workers and family members after the birth of the baby. In our study, only 5.2% women were counseled during the antenatal care. Mostly women were guided by the healthcare workers, but it was only in the form of advice. Healthcare workers should provide the physical support to the new mother. This can be done by trained and dedicated breastfeeding promoting teams. We found that the most common reason for the delayed initiation was the neonate were in nursery. This is in agreement with the study done in Ethiopia. There should be agreed criteria for transfer of neonates to NICU and policies to make sure the early initiation of breastfeeding. Poor knowledge about the breastfeeding, including the misconception about the colostrum, perceived inadequate quantity of milk, were other important factors to delay the initiation of breastfeeding. This was consistent with the findings of studies done previously in Romania. So, to conclude my study, the breastfeeding related indicators were suboptimal in our setting, providing counseling and health education for mother before, during, and after the pregnancy are important for motivating the mothers to initiate the early initiation of breastfeeding and to continue the exclusive breastfeeding for the recommended period. Training of the healthcare workers who can counsel and guide the women and their relatives about the early initiation of breastfeeding is a key factor which can increase the practice of early initiation of breastfeeding. Primary parents, women, and women delivered by the cesarean section needs more help by the healthcare workers and their family. Effective pain management and agreed policies for NICU admission are other areas which need to be addressed. A surveillance system should be placed to continuously monitor the progress and gaps in the breastfeeding practices. Future research should consider the identification of other factors causing the suboptimal indicators in other settings. These are my other contributors to these studies. My worthy professor, Dr. Lubna Ijaz Khaloon, Professor Humaira Noreen, and Dr. Humaira Bilkis. Dr. Shaista Khalid, Dr. Zainab Maqsood, and Hashim Javed. And these are my references. Thank you.
Thank
Any
you so
question?
much, Doctor. Yeah, thank you so much.
Faculty of Basic Science at AKS University, Satna. I have been actively involved in teaching both undergraduate and postgraduate students, alongside conducting the research focused on the development of biomaterials for targeted drug delivery system. Actually, my research work is not directly related to medical lines, but it is the intersect lie at the intersection of biomaterials and pharmaceutical applications. In this first slide, the overall presentation that corn cob is a raw material, and from the raw material, one of the polymer like Jailan is extracted, and that Jailan is used for the biomaterials. Jailan, actually my topic is the Jailan based hydrogels, a polymeric carrier for sustained and targeted drug delivery system. Hydrogels are the three-dimensional polymeric network and hydrophilic in nature that can absorb and retain a large amount of water without dissolving themselves. Hydrogels also possess a degree of flexibility which very similar to the natural tissues because of their significant water content. Hydrogels possess a solid-like properties such as structural integrity measured in terms of stiffness and strength. And hydrogels deform like liquid over time, so liquid-like properties. Therefore, hydrogels are often described as viscoelastic material, meaning they can store and dissipate energy like solid and liquid. This combination of being a non-dissolving, water-absorbing solid network with jelly-like qualities make them soft and flexible, yet structurally sound. When they shrink, hydrogel may shrink Next, hydrogels have various types of stimuli like pH, ultraviolet radiation, ultrasonic radiation, magnetic field, electric field, urease, metal, antibody, morphine, glucose, inflammation, temperature, ionic strength, etc. And it uh, swell wonderful, and they exhibit biomaterial for drug delivery system, for tissue engineering, for tissue plants, and etc. Next. These are the hydrogels classification. Hydrogels classified on the basis of origin, cross-linking, and biodegradability. On the basis of origin, there are two types, natural and synthetic. On the basis of cross-linking, they are chemical or physical. Chemical, it means there is a covalent bonding. In physical, there is a non-covalent bonding. On the basis of biodegradability, they may be biodegradable and they may be non-biodegradable. On the basis of preparation, it can also be classified as homopolymer. It means polymer network derived from only one type of monomers. Whereas copolymer, the polymer composed of two types of monomer in which at least one is hydrophilic in nature. Other is semi-interpenetrating network. If one polymer is linear and penetrates the another cross-link network without any other chemical bonds between them, this is called semi-interpenetrating network. Whereas interpenetrating network is the polymer is the intimate combination of two polymers, at least one of which is synthesized cross-linked in the immediate presence of the others. Next. Hydrogel fabrications on the basis of physical hydrogel and chemical hydrogel. Physical hydrogel like non-covalent cross-link, like non-covalent bonding, it means hydrogen bonding, hydrophobic interaction, stereo complex formation, ionic complexation, whereas in a chemical hydrogel, there is a covalent bonding take place. Physical hydrogels thermoplastic in nature, whereas chemical bonding is thermoset hydrogel, also called thermoset hydrogels. Next. Physical hydrogel fabrication on the basis of physical hydrogels and chemical hydrogel. Physical hydrogels like sol gel phase transition. The sol gel phase transition is a reversible process in which polymer solution, that is also called sol, transform into semi-solid three-dimensional gel or vice versa under specific stimuli such as temperature, pH, ionic strength, and solvent composition. Whereas chemical hydrogel is a volume transition phase. The volume phase transition refers to a sudden or reversible change in the volume, swelling or shrinking of the hydrogel in response to an external stimuli such as pH, temperature, strength, solvent, etc. Physical hydrogel limited shape and stability memory, whereas chemical hydrogel is a reliable shape, stability, and memory. Reliable shape and stability memory refers to the ability of a hydrogel to retain and recover its original shape after deformation or exposure to the environmental changes such as temperature, pH, and mechanical stress. Next. On the basis of these assumptions, we proposed a methodology to develop hydrogel from the corn cob. Here is a methodology. Corn cob is firstly powdered and then it is dewaxed. After dewaxing, it is delignified with the help of sodium chloride and acetic acid, and that delignified material is known as hollow cellulose. And this hollow cellulose further treated with 4% sodium hydroxide at 60 degrees Celsius with continuous stirring for 1 hour. And these the material which is dissolved in the 4% sodium hydroxide is further precipitated with acetic acid and settling down with methanol, and after decantation the xylem rich hemicellulose were obtained. The washing process was involved with methanol. Next. These are the chemical changes or chemical equation. These are the xylene component of the hollow cellulose, which was dissolved in sodium hydroxide, and it is the sodium salt of the xylene is formed, which is dissolved in sodium hydroxide solution. After neutralization with acetic acid, a sodium salt of xylene further changes into xylene, and it is settling down with ethanol, and that is the precipitate which was obtained in the laboratory. Next. Now the synthesis of the hydrogel. The fixed amount of isolated xylene which was isolated is soaked in isopropyl alcohol for 4 hours. After soaking, the addition of distilled water take place at 60 degrees Celsius. Further, redox initiator system like combination of potassium persulfate and sodium sulfite was added when temperature was reached to 40 degrees Celsius. Subsequently, varying molar ratios of acrylic acid and xylene were added after 5 minutes at the same temperature. The cross-linker N,N-methylene bis-acrylamide was added subsequently to the reaction mixture with constant stirring, and the reaction system was continuously stirred to get it progressively thicker, followed by casting onto the petri dish and kept on the water bath at 40 degrees Celsius for an hour. Next. These are the next. These are the prepared hydrogels, prepared cross-linked hydrogels. That is the chemical process involved for the preparation of the hydrogel. Next. These are the chemical reaction, proposed chemical reaction in which potassium persulfate firstly dissociate into radical anions at elevated temperature, and these radical anions abstract the protons from the xylene backbone, and the xylene backbone further reacted with acrylic acid, and there is the acrylic acid, and this is known as xylene grafted acrylic acid. After a number of acrylic acid added, and this is known as xylene grafted polyacrylic acid. Next. Xylan grafted polyacrylic acid further reacted with N,N-methylene bisacrylamide. This is the cross-linker, and these cross-link the Xylan polymers and made the hydrogels. Next. These are, now these are the physicochemical characterization of the hydrogel like polymerin, water absorption and swelling ability. This is the porosity and in vitro degradation. On the basis of this characterization, we identify which one is the most suitable for the medical purposes. Next. These are physicochemical characterization. Here is the yield, gel mass fraction, graft yield, and graft efficiency. When acrylic acid increases, the graft graft yield and graft yield increases from 2:1 molar ratio to 10:1 molar ratio. The graft efficiency was also increased with higher acrylic acid concentration and reaching a maximum value of 84.92 plus minus 9.29 at 8:1 molar ratio of acrylic acid to Xylan before it began to decrease. This might have happened because beyond this concentration, the acrylic acid homopolymerization started to increase the insignificant amounts due to enhanced combination and disproportionation of polyacrylic acid macroradical causing graft efficiency percentage to marginally diminish. Next. This is the swelling, degree of swelling. The hydrogel synthesized with acrylic acid and Xylan in 2:1 molar ratio swell the most, up to 6,824 plus minus 800%. This an increase in the concentration of acrylic acid might lead to the production of more free radical, and these changes would result in the polymeric chain becoming more entangled with NN-bis methylene acrylamide, thereby reducing the available space for the swelling to occur. And therefore, 2:1 molar ratio is the most suitable biomaterials for drug delivery system. Next. This is this is the porosity. If we discuss about the porosity firstly defined as the ratio of the volume of wires to the bulk material of the hydrogel. The hydrogel made by mixing acrylic acid and Xylan in 2:1 molar ratio shows the highest porosity of 89 plus minus 1.9%, which might be due to the copolymerization reaction that took place via free radical reaction mechanism, resulting in larger pore size as in accordance with the swelling ratio of the hydrogel. Swelling ratio and porosity was well matched with 2:1 molar ratio of acrylic acid to Xylan. Next. This is the in vitro degradation. In vitro degradation, it means the biomaterial degrade more fastly. The synthesized hydrogel having a molar ratio of acrylic acid to Xylan of 2:1 deteriorated up to 28% after 27 days. The obtained results show the hydrogels hydrogel Jailan content has significant influence on the degree of hydrogel breakdown. It means if Jailan content is higher, then its degradability will be more, and that's why maximal weight loss of the hydrogel with 2:1 molar ratio of acrylic acid to Jailan might allow the drugs sustained and regulated release over time, enhancing the therapeutic results and lowering the need for frequent dosage. Next. Next. This is the spectroscopic techniques like FTIR, Fourier transform infrared spectroscopy. This slide shows that there is a 1710 centimeter inverse, a peak obtained at 1710 centimeter inverse, which indicate the well synthesized hydrogels. The synthesized Jailan-based hydrogel spectrum shows the presence of additional new absorption band at 1710 centimeter, indicating CO stretching mode of the carboxylic acid. And this peak were observed in hydrogel, whereas in case of Jailan there is no peak was observed at 1710 centimeter inverse, and that's why this peak shows that the hydrogels was synthesized successfully. Next. This is the solid C13 CPMS mass spectroscopy. Here, this is the spectra of Jailan, and these spectra is these spectra of the hydrogels. Here, there is a peak observed at 176 chemical shift, and this was also confirmed the synthesis of the hydrogel. A new broad peak at 1407 part per million ppm was observed, which indicate the sp3 hybridized carbon units of polyacrylic acid grafted onto the Jailan backbone. The other additional new peak was observed at a chemical shift of 68.7 ppm, which might indicate the CO bond, carbon oxygen bond through which polyacrylic acid is grafted onto the Jailan backbone. The most sharp and prominent peak was observed at chemical shift of 178 ppm, indicating the carbonyl carbon of amide or carboxylic group. These additional peak observed in the solid state C13 NMR spectroscopy of Jailan-based hydrogel further confirmed the grafting, cross-linking, and hydrogel synthesis. Next. Next. This is the internal structure. Please go to back slide. Please go to back slide. Yes. This is the internal structure of the hydrogel. Here, hydrogel with molar ratio of 2:1, 4:1, and 6:1. Here also confirm that hydrogels prepared with 2:1 molar ratios have more larger pores in comparison to acrylic acid containing more. The micrographs reveal the highly porous structure of the synthesized hydrogel with acrylic acid and Jailan in 2:1 molar ratio. This was in accordance with the porosity that reveal the hydrogel porosity of 89 plus minus 1.9%. Next. This is the BET analysis, BET analysis, and it is the surface area and pore size distribution. In 2:1 molar ratios of acrylic acid to xylan have larger pores. In BET analysis also confirm the successful synthesis and maximum swelling capacity of the hydrogels. Next. Next. Yeah. Analysis of specific surface area and pore size distribution. The specific area is 2.426, and whereas the pore volume is 0.006278 cubic centimeter per gram. And this is the larger volume with 2:1 molar ratio, and that's why in the present study we optimize the hydrogels with 2:1 molar ratios of acrylic acid to xylan for drug delivery system or other biomedical applications. Next. These are the conclusions. Xylan-based green hydrogel was synthesized by employing graph-free radical graph copolymerization. Out of all hydrogels that were successfully synthesized, the one with 2:1 molar ratio of acrylic acid to xylan shows the best in vitro degradation, maximal swelling, and outstanding porosity. The successful synthesis of the hydrogel were also demonstrated by FTIR and solid C13CP mass NMR spectroscopic data. The maximum amorphicity resulted in maximum degradation as shown by in vitro degradation experiment. Its higher swelling was attributed to larger pore size, which was confirmed by FEACM and BET pore size distribution graph. All these experiments suggest that hydrogels with a molar ratio of 2:1 could absorb water-soluble drug more efficiently and can contribute to the sustained and efficient release of drugs. As a result, the hydrogel synthesized using xylan from corncob acrylic acid, potassium persulfate, sodium sulfite as an initiator could serve as a potential greener candidate to be used in the targeted and sustained administration for therapeutic agents and medication to the intended location. Next. Next. These are the references, and thank you. Thank you so much for listening me. Thank you for your kind attention.
It's all about basically the preterm and the term birth. Preterm birth is definitely a great problem of developing countries because preterm labor as well as preterm birth is associated with a lot of maternal morbidity and the mortality. So almost incidence worldwide is 55% to 18%, and identification of the woman at risk of the preterm birth is one of the critical prerequisites. So this demand is search for the new and reliable quantitative marker for preterm labor prediction. Now, to identify the preterm labor, we actually want to get some markers to identify preterm labor so that we can prevent preterm birth and its consequences. So fetal adrenal gland, that is an integral role in initiation of the parturition, and And the fetal zone of the adrenal gland is the greatest in size immediately before the spontaneous birth and quickly involutes following the delivery. Now, basically, placental corticotrophin releasing hormone acts on the fetal hypothalamic pituitary axis to release cortisol that initiates the labor process. And some evidence has shown that in the response of the adrenal gland of the fetus towards the HPA varies on the period gestation. So basically, just before the birth, during the onset of the labor, there is the increase of size of the adrenal gland. So actually, we want to get the non-invasive marker. So a lot of non-invasive marker actually already in the research papers that can identify the preterm labor, and we wanted to start our work as the point of care ultrasound to get one is the fetal adrenal volume and another was the cervical length to see whether it can predict preterm labor as early as possible. So this was our research hypothesis. Fetal adrenal gland volume can be used as a non-invasive marker for onset of the labor and the preterm labor prediction. And our objective was, as I have already discussed, to study the fetal adrenal gland volume with the ultrasonography to see the term and preterm labor, to compare the cervical length of pregnant mother in term and preterm labor cases, and to find out any cutoff value of the fetal adrenal gland volume and the cervical length to determine the preterm. So our study area was the Department of Obstetrics and Gynecology, and our study design was hospital-based observational prospective study that was cross-sectional and with two comparative groups. One is term and one is preterm. And our study period was 1.5 years. Sample size was 60, 30 of the preterm group and 30 was the term. Preterm means 28 to 36 weeks of gestation, and the term means 37 to 40 weeks of gestation for the labor cases. Now, for preterm, 30 pregnant mother with singleton pregnancy, that is of 28 to 36 weeks, manifested the signs of the preterm labor or the preterm premature rupture of the membrane. Term, we have taken 30 pregnant mothers with more than 37 gestational weeks. Now, mother before, what is basically we taken as the marker of preterm labor, that is mother before 36 weeks, 6 days of gestation, and if the frequency of regular uterine contraction occurs at 4 per 20 minutes or 8 per 60 minutes and are associated with one of the following three: either premature rupture of the membrane, or the dilatation of cervix more than 2 cm, or the effacement exceeding 50%. Now, we have excluded any hypertensive disorder in the pregnancy, gestational diabetes, over the diabetes mellitus, multiple pregnancy, poly and oligohydramnion, antepartum hemorrhage, uterine anomaly like fibroid, any sorts of fetal distress, fetal abnormality, and the IUD. So our methodology was like that. We admission through the OPD emergency or the referral from the outside. We took the detailed history with the calculated gestational age. Then we have undergone the clinical examination and confirmation whether any premature rupture of membrane was present. Because any case of premature rupture of membrane, that will ultimately land up in preterm labor. So we have done the necessary investigation like routine blood test, urine assessment, and then we have undergone the TAS, means the transabdominal sonography, and we then calculate fetal adrenal gland volume. So this is how we have calculated actually the fetal adrenal gland volume in the ultrasonography. With the point of care ultrasound, we have taken the length, width, and depth of the adrenal gland of the fetus. Then we multiplied with 0.523. That was the fetal adrenal gland volume. But definitely it will vary according to the gestational age. So we have taken corrected fetal adrenal gland volume, and the formula we have used, that the measured fetal adrenal gland volume divided by the estimated fetal weight by the USD. And this is how we have taken actually the ultrasonographic assessment. Like here I have shown that 18 years old with G1 P0 mother with 36 of gestation, showing both sided adrenal gland parameters, length, height, and the width. This is how we have taken the width, length, and the height. And we have measured fetal adrenal gland volume and also the cervical length to see whether we can see any cutoff to determine whether it is going to the preterm or the term. Actually, in this study, We have done 30 cases of the preterm birth and 30 cases of the term birth. Our main goal was to get any cutoff value of the preterm and in case of the term, so that in further study or in further we can predict this sort of the adrenal gland volume or this sort of the cervical length can land up in the preterm. So necessary management was done when we got the preterm cases. Like medically, we have given the injection dexamethasone with IV antibiotics. In obstetrics, we have obstetrical part, we have given the spontaneous onset of labor while the case was preterm and going to in that direction. Induction of the labor while cervix is favorable, and we have went for the cesarean section if cervix is unfavorable, induction failure, and the obstetric medication. So after getting the data, we have done the statistical analysis with SPSS 23 software. Student t-test was used to compare the continuous variables to determine the association among the categorical variables with chi-square test, and the p-value was taken less than 0.05 as a statistically significant. And to get the cutoff value of the both two parameters like fetal adrenal gland volume and the cervical length, we have used the ROC curve. So this is all about the results and analysis. We got this is the preterm and this is the term box. So in the preterm, we got majority in the 20 to 25 years as well as also in the term. So our final message from this chart was maximum number of mothers are seen lying in this age group of 20 to 25 years in both. Now, this is regarding the previous history of preterm labor, whether any pregnancy was associated with the preterm labor. So in case of 40% of the preterm birth was associated with previous history of the preterm labor, while in case of term, there was 10% cases having the previous history of the preterm labor. Now regarding the rupture of the membrane, we found like 73.33% patients or mothers with having the rupture of the membrane, while in case of the term, we got 50% cases with rupture of the membrane. Now regarding the delivery mode, cesarean section we have found this is preterm, and this is term. So cesarean section was undergone among 33.33% cases of the preterm mother, and in case of the 40% of the term mother, it was undergone the cesarean section. So regarding the hospital stay, we have taken as the outcome parameters. So among the 30 patients, there was mean hospital stay duration was 4.13 days with standard deviation of 1.41, while in case of the term group, we have taken 3.40 days with standard deviation of 1.40. And the p-value was 0.048, so that is significant. Regarding the essential admission following the birth of the preterm babies and the term babies, regarding the preterm babies, there was essential admission of 19 babies, that is 63.3%. But surprisingly, in the 30 term babies, there was no essential admission, because we have already excluded other antenatal risk factors. And regarding the outcome, among the 30 preterm babies, we got 13% cases with, actually unfortunately the babies died, but in 30 term babies, there was no death. So to summarize all the demographic parameter and the outcome parameter we got as preterm and term. So this is what I have already discussed. The age was minimal age, the mean age was 22.80 in case of preterm, and in the term it was 22.17. And it was the history of the preterm birth, we got 12 and 3 in case of the term. Presence of preterm premature rupture of membrane, that was 22 in case of the preterm, while 15 in case of term. And regarding the outcome, cesarean section was done 10 cases of the preterm, while 12 cases in the term baby. Baby weight was mean birth weight actually, it was 1985 gram, while the mean birth weight of the term group was 2810 gram. That is also favorable, and p-value was significant. Hospital stay was also higher in case of the preterm babies, and essential admission was 19 in the preterm, and death was 4 among 30 babies in the preterm. So this was all about the demographic parameters and the outcome parameters. But the main parts with our point of care ultrasound basis, that fetal adrenal gland volume and the cervical length. So fetal adrenal gland volume, that is the corrected fetal adrenal gland volume, we found as a mean with standard deviation. In case of preterm, it was 449.31, millimeter cube per kg with standard deviation of 64.89, while in case of term, it was bit lesser, that is 347.46, with standard deviation of 15.47, and it was highly statistically significant. Similarly, regarding the cervical length, in case of preterm, the mean cervical length was 2.54 centimeter with standard deviation of 0.70, while in case of term 2, mean cervical length was 3.11 with standard deviation of 0.85. It was also statistically highly significant. Now, these are basically the ROC curve of both fetal adrenal gland volume and cervical length to find out the basically the cutoff value. And after analysis, the ROC curve we found as the cutoff value of yes, we found the cutoff value as like 421 in case of the fetal adrenal gland volume. To say after 420, if the value is crossing more than 421, we can predict that the baby is going to have, the mother is going to have the preterm labor. We got the sensitivity of 90% and specificity of 90%. Similarly, if we get the cervical length of less than 2.75, then we found that the child or the mother can undergo the preterm labor with sensitivity of 86.7% and specificity of 90%. Yes. So regarding the discussion, this is all about the results and analysis. Now regarding the discussion, this is basically the parameters we have discussed, like history of preterm labor, presence of rupture of membrane, corrected fetal adrenal gland volume, and cervical length of essential admission. The following studies, as I have already mentioned, our study result is almost comparable with this short of the studies. We took main two studies in the next slide. Yes. Like here we can show this is the study parameter of our study along with the Agarwal study in 2018 and the WARCA study from the Karnataka 2019. Here we can compare that our fetal adrenal gland volume was 49.31. That was closely similar with these two studies, and also the cervical length in the preterm birth is also closely similar with these two studies. So, and the cutoff value in our study, it was 421. So more than 421 value of the fetal adrenal gland volume, we are predicting that the mother or the child can land up in the preterm labor. So cutoff value was closely similar with other two studies. Like here we got the 415 Agarwal et al. And while VARCS also got the 348. Limited with the cutoff value of the cervical length, our study was 2.75 centimeter as a cutoff value. Less than 2.75, it was closely similar to the preterm labor. While from Agarwal's study, they got 2 centimeter, and VARCS study, they also got the 2.5 centimeter. Now, regarding the limitation of the study, this was basically a hospital-based study and hence does not represent the whole population. Definitely, it was with very small sample size of 30 and 30 with very short period of the study, and we have done the ultrasound only regarding the onset of labor. But it is actually to be done on the regular basis, and if we can do the transvaginal sonography, it can better predict of the cervical length. Also, 3D ultrasound we could not use. So to conclude, enlarged fetal adrenal gland is likely to provide better evidence for prediction of the preterm birth. 2D ultrasound measurement of the fetal adrenal gland volume along with the cervical length is reproducible, efficacious, and non-invasive method of predicting the preterm birth. So these are all my references. Thank you.
Thank you so much, Dr. Dipanjan, for your wonderful presentation.
It is both an honor and pleasure to be invited to participate in this international conference, where we have already heard a number of very useful presentations on current topics. Today, I will be talking about postpartum infection.
Hello, Dr. Zelina.
Yes.
Sorry to interrupt. Are you presenting the slides?
What?
Are you presenting the slides?
Yes. No.
It's not
Do you
visible.
have? Mm-hmm.
We can't see your slides.
Okay. Can you see now?
Yeah, now it's visible, doctor. Please go
Okay,
ahead.
thank you. Thank you. Can I move on? Today, I will talking about postpartum infection and risk factor and management. Of postpartum infection. The postpartum infection is very common. The global incidence is estimated to be around 5 to 7%. Postpartum infection represent a significant socioeconomic and medical issue in developed and in developing countries worldwide. Incidence in our clinics, it's around 4.24%. And it's very important to note that puerperal sepsis ranks as fifth leading cause of maternal death worldwide. By recognizing risk factor and common causative agent, it's major to treatment postpartum infection and prevent the complication and sepsis. A sedentic spread of the infectious agent into upper reproductive tract and may endometritis, and also in contrast, iatrogenic trauma to the abdominal wall or perineum can cause a surgical site infection. Endometritis is the most frequent postpartum infection, and its incidences are about 1 to 3% after vaginal delivery, but increase to 5 and 6% after when we have risk factor. It is important to know that endometritis is 10 to 10 times more common after C-section compared to vaginal delivery. The main symptoms is fever above 38 degrees Celsius usually appear between second and 10th day, day postpartum. Also, we have pelvic pain, uterine tenders, subinvolution of uterus, and false milling lochia, along with general symptoms such as weakness or headache. When we make the differential diagnosis, it is important to keep in mind always mastitis, urinary tract infection, or sepsis, ileoseptic pelvic thrombophlebitis. When we're talking about risk factor, it is a premature rupture of membranes, chorioamnionitis, bacterial vaginosis, frequent vaginal examination. Also, maternal factors like obesity, diabetes mellitus, hypertension, immunocompromised condition. It is one of the key preventive measures is preoperative antibiotic prophylaxis. It is important to give patient first generation cephalosporin, like example cefazolin 1 gram, 1 hour before incision, and that has proven to significantly reduce risk of infection after C-section. Also, studies have shown that vaginal irrigation immediately before elective C-section can future reduce the postpartum complication. When it comes to treating postpartum infection, empirical antibiotics therapy and also early recognize of pathogen agent is very important. Starting antibiotics promptly before culture results are available prevent complication and sepsis. On next slide, You can see that the most common pathogens identified in our clinics are Escherichia coli and Enterococcus, slightly less isolated Klebsiella pneumoniae and Staphylococcus aureus. A major challenge in treatment today is increasing resistance of bacteria on commonly used antibiotics. And for this reason, World Health Organization has created a list of priority pathogens to focus on fighting antibiotics resistance. Also, antimicrobial resistance is also called silent pandemic. According to the World Health Organization, antimicrobial resistance was occurred 1.27 million deaths worldwide, and it's projected that by 2050 it caused 40 million deaths worldwide. And because of this, American Society of Infectious Disease introduced acronym ESCAPE, which highlights the bacteria with the highest potential to develop the antimicrobial resistance. And it is important to pay attention to Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumonia, Acinetobacter, Pseudomonas aeruginosa, and Enterobacter species. The danger of these pathogens lies in their ability to adapt and persist even in a modern healthcare system. According to American College of Obstetrics and Gynecologists, the gold standard treatment for postpartum endometritis is combination of clindamycin and gentamicin with or without ampicillin. This recommendation, based on the meta-analysis in 2050, which include 40 randomized studies. Therapy usually continued 24 to 48 hours after the fever subsided, and white blood cell counts normalize. And let me share with you one case report with combined postpartum infection. Then it's a 38 years old patient who was pregnant 33 weeks and with premature rupture membranes. She underwent C-section, and it's important to note that in vaginal swab and also in uterine swab, we found Escherichia coli, as also in cesarean wound site. The patient subsequently underwent reoperation, during which did wound debridement and resuture. And this case report highlights the importance of recognizing combined postpartum infection, which can require prompt surgical and antibiotic intervention to prevent postpartum complication. Thank you for your attention, and welcome to Belgrade.
Thank you so much, Dr. Zelina, for your excellent presentation. Is
Thank
there
you
any
so much.
questions for Dr.
What we have been intended to implement is the model so-called the effect of midwifery lead continuum of care to see its effect on the maternal and newborn outcome. So as you can see from the slide, Ethiopia is the second most largest populous country in the Horns of Africa or in Africa. It accounts 126 million populations, and the other unique feature that you need to know for the audiences is that our country is known by the long distance runners, and there are also so many cultures which have been registered by the UNESCO, which is very ready to be visible for the international audiences. To give some brief pointers on the healthcare systems of our country. So our healthcare system have been organized into three-tier model. It starts from the health post to the tertiary levels. So that at the very lower level, at the community level, we do have the health posts. It serves to 300 to 5,000 people. And basically the primary care in the health post level were carried by the health extension workers. And recently, the government has also reorganized the structure of this health post into the basic and the comprehensive ones. And the other tier of our healthcare system is the health centers. Each health center will need to accompany around 25,000 people. And at this setup, the mid-level carers professionals are the one who give the healthcare system. And the final destiny will be the general hospitals, which can also see cases which have been referred from those primary hospital health centers. And the final endpoints of our healthcare system is the specialized hospital, which is a pinpoint in our healthcare system where most specialized personnel were found to manage those complications. As a country, the first healthcare policy have been established in 1993. When it comes to specifically to the healthcare systems, the maternal healthcare system have been also practiced, but there are so many fragmentations in our system. So when you can see the global maternal mortality, the global maternal mortality has been declined in the last few decades by 14%. However, still there are a high maternal and newborn mortality have been found in the globes, and from those high number of maternal and newborn mortalities, from those high number, 90% of these mortalities have been occur still in low and middle countries. So as a factor, poor qualities, humanitarian crisis, resources have been one of the factors that can be described for this poor outcome. When you see the Ethiopian circumstance, Ethiopian has been also implemented so many initiatives in order to combat and reduce the maternal and newborn mortalities. Expansions of the healthcare workers, expansions of the facilities, recruitments of more professionals, including midwives. So when you compare the maternal mortality of Ethiopia from the previous incidents, there is a significant reductions, but still there have been a huge gap when you compare to the sustainable development goals set by the United Nations. Still the maternal mortality is 195 per 100,000 population. So as a factor, as I mentioned before, the poor access to skilled birth attendance and poor system of our emergency care system is one of the factors which can facilitate for the high incidence of maternal mortalities. Lack of continuum of cares, including the socioeconomic barriers, and poor quality of care is one of the few factors which can facilitate the incidences. So as an approach, in order to alleviate these factors, we implement this midwifery lead continuum of cares. As you can see, this model of care is aligned with the philosophy of the midwifery cares. It promotes a person-centered approach, value the woman midwifery relationships, and it optimizes the physiological, the social, and the cultural processes. So when you see this midwifery lead continuum of care as an intervention, it can be implemented in two different modalities. The first one is the case midwifery, and the other one is the team midwifery. So in our circumstance, we use the team midwifery, which is recruiting 5 to 6 midwives in single facilities in order to follow the woman from preconception to the early postnatal period. So this model, it prioritizes skilled midwife as a primary care providers. It is widely implemented models, especially in British, Americans, and Netherlands. It have been implemented like 2 to 3 decades back, and most of the European have been implemented these models. But when it comes to the low and middle income country, this model has been a new model. So it have been so many evidences that this model have been proven to reduce these unnecessary interventions, and it also improve maternal and newborn outcomes. Here are the 5 guiding principles while we implement this model of care. It is based on the equity, person-centered, high quality, is coordinated primarily by the midwife, and the 5th point is integrated in collaborative care so that the midwife will collaborate and integrate the cares whenever they encounter complications. So the global papers also clearly stated that this model of care have been effective while it have been implemented as a universal coverages. One of the study which have been conducted by 2022 stated that if this model of care have been achieved as a universal coverage by 2035, this model could avert 67% of the maternal deaths, 64% of newborn deaths, and 65% of stillbirth. This clearly show that the model have been effective if it is implemented by most of the country. Even if it is implemented by 25%, it have been elevate the maternal deaths by 41%, newborn by 39, and stillbirths by 26%. Having these evidences and having so many evidence from the other countries, we decide to implement this model to assess its effect, whether it have been improved maternal and newborn outcomes in Ethiopia, specifically in Sidama district. During the interventions, we implement a randomized control trials, and we have been recruited 478 low-risk pregnant women into different sites as the control and the intervention site. In both sites, we recruit low-risk pregnant women so that the women in their newborns are followed prospectively until the early postnatal to assess the maternal and the newborn outcome. And finally, we compare this midwifery lead continuum of care with the shared or the standard model which have been implemented by the Ministry of the Ethiopia. As a primary outcome, we assess the spontaneous vaginal birth in the preterm as the primary outcome. However, we do have also the secondary outcome we assess like cesarean section, the rate of preterm episiotomy, and like. So we follow the mothers for 8 prospective menses, and finally we had these results. So at the end, we compare mother who have been followed in the intervention site versus mother who have been in the comparison or in the shared care. At the result, those women who have been in the midwifery lead continuum of care have higher chance by 88% higher chance of having the spontaneous vaginal births. However, those women in these interventions groups were less likely by 84% of having preterm births, 67.2 low risk of cesarean sections, and 41.8% of low risk of having this episiotomy. So the result of this study also clearly show that even if it is implemented within its own implementations, it clearly show that this model of care have been substantial effect on improving this maternal and newborn outcome. And the WHO, the World Health Organization, has also declared that for low-income country to adopt this model in order to improve their maternal and newborn care. As a conclusions, this model of care improve maternal and newborn outcomes in low resource setting like Ethiopia, and this midwifery lead continuum of care empowers midwife with a great professional autonomy since they are the primary providers determining these models and allows them to provide continuously and high quality of care through the maternity period. So when you see the implications of the study finding, it is an evidence for scale up because, as I said before, in Ethiopia, there have been so many interventions and approach have been deployed to improve maternal and newborn outcomes, so that this is new, it's an aspect so that it can be an evidence for scaling up. The other one is it is a potential for the health system to strengthening, especially by improving the quality, since the midwives were working with the other professionals, they are a chance of acquiring new skills so that it improves the quality, it enhances satisfactions of the woman, and it has a great effect on the policy and practices. Thank you.
Thank you for